CataractCoach.com, artificial corneal endothelial implant for this very challenging case where the risk of graft rejection is high. Now, yesterday on our podcast, we featured this, and we had Dr. David Loughnane explaining to us how he used this device in his very complicated eyes. That podcast was amazing. You really should check it out. Listen.
What it does essentially is it compresses the cornea in the center. It will relieve the bullae, and the nutrients should hopefully go around the edges of the residual cornea. And so I've done it. I've done 3 of them now. One of them was in an elderly patient with some dementia and blistering infected bullae. And we did that, and it's clamped down the cornea. There's no bullae now. So her eye should be safe for the remainder of her days. And because it's a piece of plastic, essentially, you don't have the same drop requirements longer term, though you do need to keep that suture in for a good few months.
So let's get back to this case now. Complicated chronic uveitis, pressure issues, previous cataract surgery, decompensated cornea, DSEC already done, trabeculectomy with hypotony requiring those compression sutures that you see there. DSECs rejected, failed bilaterally from chronic uveitis. So you got a high risk of future rejection. So what are you going to do here? So here's peeling off the existing endothelium, which is already rejected and failed. So that's going to come out of the eye. Now this new device, this EndoArt, it's a permanent synthetic implant that's basically designed to be a physical barrier, blocking the ingress of fluid from the anterior chamber into the cornea. So by sealing off part of that inner cornea, the EndoArt can relieve some corneal edema without functioning endothelium. So it's interesting. It's a copolymer of hydroxyethyl methacrylate and methyl methacrylate. Say that 10 times fast. It's, again, dome-shaped, it's optically clear, and it's foldable, made of hydrophilic material that's designed to adhere to the posterior portion of the cornea. And it's about 6 to 8 millimeters diameter. And let's take a look here. So there we go. There's the artificial device. And that, you got to put in the correct orientation. And there's a little letter on there, a letter F, so you can tell if it's the right way or the wrong way. See the orientation of the letter. And then now, once you get this thing into position, you place it inside the eye here. And again, it's completely made of plastic. It's completely man-made. There are no living cells on it. And that's placed into position here, pushed up against the endothelium where it's going to act as a physical barrier. There's a gas bubble. And if you listen to the podcast, you know that he's going to put C3F8 in there for it to last a little bit longer. And then something interesting, to hold it in place, there's actually a temporary full-thickness suture adhering it in place for at least a few months. So again, this is a super complicated eye, and I understand why he's using it. And he's got a pretty good record so far. He says he used it for 3 eyes at this point, and all have done reasonably well. But again, things take time, and 3 is obviously not a huge number of patients just yet. But it would be nice if this does work. You can use it in these very complicated cases, or even in other countries where you don't have access necessarily to tissue, to endothelial tissue. There's a bigger bubble going in there, and it looks like it's adhering in the correct position here. Now I'm interested to see how he does that suture. And so this looks like just suturing up the incision with probably a 10-0 nylon. And then here's another one, suturing that up, achieving some airtight status. Interesting to see those compression sutures on the bottom of the corner of your screen there. And now here comes your full thickness suture through the cornea, through and through, and that's just going to help tack this in place. So this will be on the superior cornea here, entering, and it's going to get full thickness. Look at that. Not seen this technique done before. This is something new to me. So I'm going to pull this through here. Now this device, you'll have to do your own Google homework, may not be available everywhere. I'm pretty sure it's not available in the USA. But here at the end of the case, there it is. There's a full thickness suture, tacking it in place. And I trust that won't leak. And a little bit more on the gas bubble, or adjust the gas bubble size here. And then this patient does very well. So interesting concept. It's actually a physical barrier to prevent fluid from entering the center of the cornea. So you won't get those central bullae and central damage to the endothelium or the corneal stromal layer. This fake endothelium is going to prevent that extra fluid from going in there and hopefully dry out some of that central corneal stroma. Very interesting tissue. And hey, remember, check out that podcast. It's amazing the things we learn on that podcast. New podcasts everywhere. You find podcasts, Apple, Amazon, Google, Spotify, you name it. Every Sunday, a brand new podcast. This is the top podcast in all of ophthalmology.